I will be the host for this last session of Respectful Maternity Care's webinar. Today, our amazing speaker, Dr. Hazel Kedel, will share about an exciting topic. It's about supporting birth trauma. So, before we get started, let me introduce Ruang Bidan Indonesia by playing our profile video. For the operator, please play the video. Okay, thank you. So, first of all, let's take a little time to pray. Hopefully, by joining this webinar, we can learn more and be more thoughtful midwives. Pray together, begin. Finish. This time, I was accompanied by our lovely moderator, midwife Iza, as the moderator for today's session. So, I will introduce our moderator with her CV. All right. Midwife Iza is a graduate from Bachelor and Professional Program Midwifery, Faculty of Medicine, Universitas Airlangga. And also her latest professional experience are co-researcher of Respectfull Maternity Care Midwifery Programs Studi, Universitas Airlangga. Also research officer of JTIM Adelaide Kaltim Research and Development, and also research officer of NEAR-MIS. And then for her latest community and volunteer experience, are coordinator of collaboration, Advanced Research Center, coordinator of vaccine participant registration, and also founder and chief technology officer of Ruang Bidan Indonesia. And then she also have some achievements, for instance, as poster and oral presenter at ICM Triennial Congress, and also runner-up poster presentation at IPKIN West Sumatra webinar. And she also already has some research publication and has some organizational and leadership experiences as well. So Before we move to Iza, if you have any questions during this presentation, please type them into the question box below. We will also have time for questions at the end, and we will let you to speak or ask. Now, without further ado, we will turn the time over to Midwife Iza. Hello, Midwife Iza. How are you?
Hi, Midwife Geza. All good.
Okay, now the time and screen is yours.
Okay, thank you, Midwife Geza, and good morning to all participants. Welcome to last session of Ruang Bidan Indonesia Midwife Forum, Respectful Maternity Care. And my name is Iza. With nervous, happy, and enthusiastic, I will be your moderator, and we will be looking at another intriguing aspect of midwifery with Dr. Hazel Kettle. And before we dive into our exciting talks, let me give you a quick overview of what we have for you today. First, we already passed opening and introduction of Ruang Bidan Indonesia, and we will have expert panel discussion by Dr. Hazel Kettle, will be followed by Q&A session and close with documentation. And please note, guys, that I will assist you in activating the show caption so that Zoom will transcribe our English speech into the text. However, this caption is not available in Bahasa, but don't worry. If you have difficulty understanding the material or the message given by Dr. Hazel, or you want to ask in the Q&A session directly, please let us know on the chat box or just click raise hand tools on Zoom. Okay, wait, yeah, like this. So, jadi teman-teman, saat ini caption sudah tertera di bagian bawah. Jadi nanti percakapan kita dalam bahasa Inggris diubah menjadi teks seperti di bawah sekarang. Meskipun begitu, teks ini hanya tersedia dalam bahasa Inggris, tidak tersedia dalam bahasa, tapi teman-teman jangan khawatir. Kalau misalnya ada kesulitan dalam memahami materi atau nanti mau bertanya secara langsung, bisa tulis saja di chat box, atau misalnya teman-teman langsung mau bertanya bisa klik raise hand di bagian tools Zoom, begitu. Okay, now let's start our expert panel discussion with last topic in this series, supporting of birth trauma. Today we have a beloved midwifery expert in this field, who will provide us with valuable insight into the topic that we will explore today. Dr. Hazel Kettle is a midwife, author, lecturer, researcher, and the director of academic program for midwifery at Australia, Western Sydney University School of Nursing and Midwifery. We know that she also wrote a book called Birth After Cesarean, Your Journey to a Better Birth. I think almost of the participants already ordering. And Dr. Hazel Kettle is also in charge of research for the birth experience study, which is the biggest study of maternity experiences. And in September 2022, she was hired by All for Maternity. Please, guys, surfing on the internet about All for Maternity, you can have another side of midwifery. So now, without further ado, let me invite Dr. Hazel to the forum. Hello, Hazel.
Hello, Isa. How are you today?
All good. How about you?
I'm very good. Very happy to be here with these smiling faces.
Yeah, thank you. We're so happy to have you here, and I'm a fan of your work. And if I'm not mistaken, I already met with you in the ICM Congress in Bali. And we can wait to hear your story and experiences. And yeah, it's screen and time for you.
Okay, well, thank you very much. I will just share my screen and just, where is it? Here it is here. Okay, so let me just get things all set up. So this week, thank you for coming back for the final week. And this week we're going to look at birth trauma, but also we're going to look at debriefing, which is an important aspect for women if they have experienced birth trauma, and what you can do, what we can learn from what women said about their debriefing experiences. So it's kind of two topics. I've kind of mashed a couple of presentations together, but I think, you know, the messages will be really important for you all to learn. So this data, again, is coming from the birth experience study that I introduced last week, when we had a lot of closed and open text comments or questions throughout the survey in 2021. And we do now have our Indonesian version that is now being worked on as well as part of the birth experience study international collaboration. I'm going to start with something a little bit different. At the beginning of our research in the birth experience study, I collaborated with a poet. Now, would you believe it? I collaborated with a poet. And this beautiful woman called Pixie Willow wanted to create poems from the women's words in the survey. So we worked together, and she got some de-identified comments from women, and then she created this series of poems. And the first set that she created were all about birth trauma. And we published an article on that. It's not open access, so I'm going to see if I can drag and drop it into here. I'm not sure if I can. Oh, I can. So I've just shared, as I'm the first author, I can do this. I've just shared the actual PDF of it if you can't access it as an open, because it's not open access. But that QR code will take it to you. Now, when she started sending me the poems, I was really impacted by how emotive they were. And so this paper actually talks about how we work together, how I was impacted by them, and how she created those poems. And on the next slide, and this will start straight away, which is why I'm letting you know about it, is I've actually got a reading of one of the poems by Pixie Willow herself. So it's going to come onto the next slide, and soon you will hear her reading a poem called Screaming Out to Stop, or something like that. Something about screaming to stop. And I want you to listen to this poem, and I really want you to put in the comments how it made you feel when you were listening to that poem that you're going to listen to next. So is everyone ready to listen to a poem? Yeah? Okay. Let's see if it works. Where's my little button gone? There we go.
My dreams crushed, hearing the baby's heartbeat in distress. Told, stop worrying, labeled a broken mother, still feels so fresh, eyes well up. She keeps screaming out to stop. Still screaming to stop, just ignore her, keep going, we're on the clock. Betrayed and violated, frivolously dismissive, my expectations too high. In a fragile state, still feels heavy with regrets. Why haven't you pushed him out yet?
Okay, so there was the poem, and she created those out of the words that women wrote. So how did you find that? Did you think it was a little bit different to just reading a comment? Did it impact you in a slightly different way? I'd love to hear your thoughts on that. She's now written over 40 poems, and they're not all birth trauma. There are a variety of poems from trauma, but through to hope and positive experiences. And we hope that we can publish this as a book in the next 6 months or so. We might have to self-publish that one. So there might be an opportunity for you to get hold of that book and to read those in poetic form. And some of you might not get poetry. Some of you might like poetry. But I think what it does is that it reaches you on a different level. It's a creative form of writing. And I personally think it's very powerful. So if you have any thoughts, please pop them in the chat box. I'd love to hear what you think about listening to that poem. So what are we really talking about today? We're going to be talking about birth trauma. And I shared this slide last week, but I thought I'd go into a little bit more detail about it today. People often ask, what is the definition of birth trauma? And birth trauma, you know, there's a couple of definitions I think we have to explore. One is that it is Cheryl Beck's famous quote, that birth trauma is in the eye of the beholder. And what that means is that it is up to the woman to say what her experience, whether or not she experienced birth trauma. It is not for us as clinicians to tell her that she's had a traumatic birth. And for those of you that have been working as midwives, you'll understand that women come away with different perceptions and experiences, even if it looks the same on paper. But I think we also have to understand, well, what does encompass birth trauma? What does birth trauma cover? And that's where I've come up with this umbrella term, that many different things can result in the woman feeling that it was a traumatic experience. And there can be more than this. This is just some of the ones that I pulled out of qualitative research. Now, we talked about obstetric violence last week, but there could be the physical trauma, so the perineal trauma or the trauma of the cesarean scar. It can be a lack of support, both from neglect through healthcare providers, but also maybe a lack of support from the people in her family or immediate family and friends. There can be a fear for her own life, but also a fear for her baby's life. And ultimately, a loss of control, feeling like you had no control over what was happening to you. It was like you were the observer and everything was happening around you. And you can see that quote there, but you know, below that, where she says that she feels less of a woman because of that. And the statistics there is, this is what we found from the birth experience study of nearly 9,000 women, that 28% of women described their birth as a traumatic experience. So the next thing I'm going to go through is I'm actually going to look at what we had and what things increased birth trauma rates and what things decreased birth trauma rates. And I think that's really important to think about, especially with our rising intervention rates. Can everyone hear me okay? Yeah. Okay, so the first one is induction of labour. Now, here in Australia, we've got nearly 44% of first-time women primates being induced in Australia. That seems a very high amount. And we throw it around like it's not important or like it's got no impact at all on the birth experience. But in our survey, we looked at whether or not women had been induced or whether they'd had a spontaneous labour, and then cross-referenced that to birth trauma. And what you can see here is that, remember, the standard is 28%. So if there's an arrow going up, that means it was higher than 28%. If the arrow goes down, it was lower than 28%. So we can then look at what changes those rates. And we can see here that induction of labour increased that birth trauma rates nearly by 10% more. So induction of labour had higher birth trauma rates. However, if the woman went into spontaneous labour, that decreased it to 23%. So induction of labour does have an impact not only on the cascade of intervention, but on the cascade of trauma. And here's a quote here. "My labour was induced. It was too hard to handle. They did not ask or listen to the birth plan, and I didn't get the physiological placenta birth. They also placed in the Synto, so Syntocinon, while I was asleep from the epidural without my permission." That's actually legally an assault. if they don't have her consent, or maybe they had her consent before, but then they've put it in while she's asleep, that's actually not okay. You should always be checking and getting consent continuously. It's not a one-off event. So you know how I like to hear from you. This isn't just me talking. I want you to talk to me as well. What do you think about this? Do you think, have you seen induction, and do you see how it could cause increased trauma? What are your thoughts about that? Does this surprise you, or does this not surprise you? What are your thoughts? Please write it in the chat, because I love to hear from you while I'm talking. Okay, so let's look at the next thing that impacts birth trauma. And this is mode of birth. It really is impacted by the type of birth women have. Now, it's quite significant, isn't it? Look at these numbers. If a woman had a cesarean before labor, we sometimes call that elective cesarean, planned cesarean, it stayed the same. And important to note, it didn't decrease it. Yet I don't know about you, but I hear about many women that are told, oh, if you want to avoid a traumatic birth, have a planned cesarean. But our numbers show it doesn't decrease it. It still keeps it the same. If the woman has a cesarean during labor, look at this, 57%. That's from 28% to 57%. So from our survey, we can see that having a cesarean during labor really increases that birth trauma rate, nearly doubles it. And then instrumental birth, again, up to 55%. Now, sometimes people might want to say, oh, that's due to the perineal trauma. But this isn't. The cesarean during labor isn't. So it actually shows you there's more to birth trauma than only perineal trauma. And then what happens if a woman has a spontaneous vaginal birth? It goes down to 15%. So I think we do need to identify that mode of birth does actually happen, make a difference, sorry. Mode of birth makes a difference on that cascade of trauma. The cascade of intervention that can result in a cesarean during labor or an instrumental birth goes alongside this cascade of trauma, which means the women are more likely to feel that they've had a traumatic experience. And here's a quote here. My needs were not considered. I felt like a piece of meat with no rights to my body. I was forced into a cesarean when there was no emergency. What are your thoughts on this? I can't see any messages yet in the chat, so come on, get chatting to me. What are your thoughts on, oh, here we go. Ada says, I'm not surprising. Induction increases birth trauma. My clients have much birth trauma after they get protocols until 1 to 3 years after birth. I agree. Honey, induction without consent will increase birth trauma. Absolutely. Yeah. They can't control the effect and contraction following. Absolutely. Once you've got that induction and the medication on board, you're almost set up to fail, because women are then not encouraged to get off the bed. They're encouraged to stay on the bed, lying still the whole time. And, you know, if I'm going through a contraction, I want to be up and moving and being able to work through the pain. Lying there still is just going to make the perception of the pain worse. So, yeah, I think we've got a lot to do with that. Excellent. I'm glad that some chat's coming through now. So what are your thoughts on this? You know, there are many, many experiences where women are saying that their cesarean during birth or their instrumental birth is a traumatic experience. And now we've actually got the statistics to show that it impacts that experience of trauma, which I'm now calling this cascade of trauma. All right. What's next? Now, some of the things I'm going to be talking about are demographics of women in Australia. So subgroups of, sub sounds bad, but groups of women as part of the main data set that we wanted to look at to see whether they were more impacted by birth trauma. So let's have a look at that. Oh, sorry. Sometimes my little controls hide underneath my thing and I can't see it. I'm going all over the place. Here we go. Mental health also has an impact. So if a woman had a diagnosis of a mental health issue in the past, such as depression or anxiety or many other mental health experiences, they had higher birth trauma rates. And that's a concern, isn't it? Because if we then understand that experiencing birth trauma can lead to more mental health issues, imagine if you've already got a mental health diagnosis, and then how vulnerable you will be once you've then experienced a traumatic birth. We do know from a systematic literature review done at our university that a traumatic birthing experience also leads to higher rates of PTSD. And an international review looked at PTSD after 6 months post-birth. Again, there were higher rates when women experienced instrumental vaginal birth or cesarean section, and least common in a spontaneous vaginal birth, which links it, doesn't it, to the previous page where we showed you the different birth trauma rates dependent on model of birth. And here's this quote here. She started showing signs of PTSD 3 months after the birth. Hang on, I'm just going to quickly hold my meeting controls. 3 months after the birth, and I still suffer from PTSD 2.5 years later. It has strained my marriage and made being a mother 100 times harder. It made me have to fight the constant feeling of being a failure to my baby. Isn't that shocking? So we know that some women who have experienced birth trauma will go on to experience PTSD. Shows us how important that is. Okay, so in Australia, as you know, we do have First Nations women, and these are women who identify as Aboriginal and or Torres Strait Islander. And across Australia, we know that they have massive disparities in health. They have higher rates of maternal mortality and morbidity and neonatal morbidity and mortality compared to non-Aboriginals. As you can see here, First Nations mothers have high rates of premature birth, so 13% versus 8%, perinatal deaths, 17.3 versus 9 per thousand, and then a lack of birthing on country options. So we had a look particularly at this group of First Nations women. And what we can see is that we have an increased rate of 37%. And instead of 1 in 10 experiencing obstetric violence, it was as high as 1 in 6. Now, you might wonder if this has any relevance to you, but I'm sure you have groups of women around Indonesia that are maybe who have a decreased socioeconomic status, or maybe they come from a specific cultural or ethnic group. And I know all those years ago when I was in Indonesia, there were groups of women and families that lived just off islands as well. So, these are particularly groups of women that might be more vulnerable and likely to experience mistreatment and birth trauma. And with this quote here, what was really important to her was that she wanted to take the placenta home to bury it under a tree, and that tree becomes the tree of life for them, and that's a cultural practice. But the babe, she was just told that the placenta's gone, like it's been gone away for testing, and she never knew what happened to that. And maybe for the midwife, she didn't think it was important. As we know, most of our placentas end up being incinerated. But for this woman, it was really important, and it was then a lack of cultural practices that she wanted to do. We also then looked at women who came from a culturally and linguistically diverse background. And to be honest, if you were in Australia, that would be Indonesian women in Australia. And so this will impact those that have moved to Australia to have babies. We know that in New South Wales alone, let alone the whole of Australia, that we have 37% of women were born overseas. We have a large migrant background in Australia. I myself am a migrant. I was born in England. and migrated to Australia. And it's one of the things I love about Australia, is that we do have such a diversity of culture, and it's something that makes me very happy, especially at my university, which is in Western Sydney, which means we are in a real mix of cultures that come to our university. And our top 4 regions are Southern Asia, Southeast Asia, Chinese Asia, and the Middle East. And we looked at their experiences, and we did do it in different languages. So we had it in Arabic, Chinese, Filipino, Hindi, Persian, Thai, and Vietnamese. And women from those non-English backgrounds, they did have higher rates of birth trauma, and a lot, but it's still higher, and higher rates of obstetric violence. And this woman here, you know, she wrote that in her language, and she said, I had severe physical and mental damage. So that's something we also need to be aware of, that when people are in your country who maybe do not come from your country, and you would have a large migrant population coming through Indonesia, and then staying in Indonesia, that, you know, their experiences of maternity care could well be worse than born Indonesian individuals. And then we have young parents. Now in Australia, we don't have a large amount of young women, and we see it as under the age of 24, whereas maybe in Indonesia, you would see that as younger. And it's 11% of birthing women in New South Wales and across Australia. There's not much difference. But we do see that they have higher rates across Australia. We know that they have higher rates of perinatal deaths, 15.8 versus 8.8. And so we had a look at what their experiences were for under 20, for those that said they were 24 years and younger. And bearing in mind, even though 24 might not seem that young, they could have had a baby in the previous 5 years. So they're 24 and they're looking back. So they may have had the baby, you know, at any time in the previous 5 years when they were younger. And what we can see here again is that being a young woman having a baby meant you were more likely to experience birth trauma and more likely to experience obstetric violence. So remember, this has gone from 28 up to 41%. That's really quite significant. And this quote, you know, if you imagine yourself as and so this participant was between 18 and 20, and so she's had her baby, you know, maybe in the last year, but maybe in the years beforehand. If you put yourself into her shoes, imagine what it would be like for her as a young woman. Whilst I was in labor, they refused pain relief and told me I wasn't in labor, so she wasn't believed. Wheeled me naked past the front where visitors are to birth suite. Couldn't sleep for 2 days as my son and the midwives kept waking me. I was crying with the lack of support. I received no debriefing. It was horrific. I have a video of the birth, and I often find myself looking at it and crying. This is a very impactful statement. And even to think that she could be exposed as she was in labor, where other people could see her, and you know what that could do for you, for a woman of any age, but particularly a young woman when she's feeling so unsure of her body anyway. So we know that we can see that birth trauma is higher in young women, and they're also more likely to experience obstetric violence. And so you can think about that for your practice when you are caring for younger women. And if you know what your percentage is of birthing women that are young, do let me know in the meeting chat. Or if you've got any experience of caring for women as a midwife who are young, please share your stories in the chat, because I think we often young women, especially if they are unmarried, are going to get a lot more social stigma, and the midwives may be a little bit more judgmental to their experience, and therefore that can come across as being not believed, as being not respected, and therefore birth trauma, resulting in birth trauma. So if you can think of any examples or your thoughts, I'd love to hear from you. So mistreatment, I'm not sure if I showed you this. I think I did show you this last week as well. And just to show you that, birth trauma can encompass, that umbrella term can encompass all sorts of things. But mistreatment and obstetric violence is one of those. And when we measure for mistreatment, which is asking if women had yes to any of these things, our number is higher than our obstetric violence and our birth trauma rate. So there's something quite unique about asking these questions and getting this rate. I know in the Netherlands, where we've also got data, that's 20%, and it's higher. Ours is higher. And when we do the birth experience study in Indonesia, it'll be interesting to see what that rate is as well, because we're collecting international data on this. So what can we do about it? And also, will women just experience birth trauma, mistreatment, and obstetric violence, and across the models of care? Does anything that we do in maternity care make a difference? And I know I quickly touched on this last week too, but just to show you that having continuity of care with a midwife makes a massive difference. So our birth trauma is this blue line here. Absolutely, Hanny. Yeah, young mother do need more support, and we must respect the situation and the reasons behind being pregnant. Absolutely right. There's not many young women that actually chose for that to happen. It may have been a mistake, but there could also be a lot of trauma that's come along with it for that reason. And that reason could be through sexual assault. It could be through child abuse. It could be through incest. There can be scenarios. So then for a woman to then also lack of options for termination of pregnancy or safe abortion care. If there's not that option in their countries, then that makes it harder to make reproductive choices. And yesterday, I saw on social media that yesterday was Safe Abortion Care Day, which is, I don't know what the rules are in your country, but we have recently, across Australia, we've had some changes, some positive changes in the reproductive rights for women with safe abortion care, in the fact that we've taken it out of the legal framework and put it into the health framework. And we've also lifted the amount of hoops women have to go through to be able to access termination services. And now all midwives can actually prescribe the medical abortion pill to women who are looking for abortion services. So midwifery is going to have more of a role in this in Australia in the next few years as we start setting up those services, which I think is really amazing, because if you think of Australia, often we would only have those services in the main cities, and then in the other areas nothing at all. So that might be a conversation that is uncomfortable to have, but safe abortion care is part of our scope of practice, isn't it, as midwives? So if we look again across this line of birth trauma, we can look at what goes above it, and the green is the birth trauma. We can see that having a fragmented model where a woman comes along and sees a different midwife every time, or a different doctor every time, actually increased birth trauma rates. In one of the models we have in Australia is you might go and see your doctor, your general practitioner that you see for everything else, your family doctor, and then you might go into the hospital to have your baby. And so again, it's quite fragmented, and they again had higher birth trauma rates. But if they had a private obstetrician or a midwifery group practice, which is continuity care with a midwife, or if they had their own private midwife, you can see how much that dropped down. So model of care really does have an impact into how women experience their maternity care, and that relationship-based care, that continuity, has a really big impact. I'd love to hear from any of you if you do work in continuity models, and how you support women to help them not have a traumatic birth. The other thing is bringing it all together, right? So on the previous page, we could see that the private obstetric model, midwifery group practice, and privately practicing midwives had lower rates of birth trauma and mistreatment and obstetric violence. However, we also know on that earlier slide the impact of mode of birth. Do you remember that? The highest number was cesarean during labour, then it was instrumental birth, then it was cesarean before labour, and then it was vaginal birth had the lowest rates. So let's do a fancy graph now that actually brings together the type of birth and model of care, because that gives us quite a big insight into what else is going on. So here we've got the fragmented care, and you can see the different types of birth here, and this is vaginal birth. And emergency cesarean during labour is grey. So this is cesarean before, cesarean during, instrumental, and vaginal birth. And the lowest rates of vaginal birth were with a private obstetrician. Now remember, vaginal birth had the lowest birth trauma rate, like it was 17%, wasn't it? So then we want to look at, well, which model of care has the highest vaginal birth rate? And look at this: midwifery group practice, continuity of care with a midwife, or continuity of care with a private midwife, and a lot of this is done at home. A lot of those are home births. They have much higher rates of vaginal birth. So if we're then trying to look at a model that not only has decreased birth trauma rates, but also has higher modes of birth that has decreased birth trauma rates, then here is what we're looking for: midwifery group practice and private practicing midwifery care. And then we have done some statistics called logistical regressions, where we've actually taken out risk factors and other issues that might impact that. And when we've made it all equal, we also see those lower rates in privately practicing midwife and MGP as well. Okay, so looking at all the stuff that we've looked at in this presentation, in those numbers, you know, there's the top 8 things that have the highest amount of birth trauma, and the demographics of women that have higher rates of birth trauma, and they're listed in order of the highest reported rates. So cesarean during labour, and then instrumental birth. So if people want to say to us the type of birth doesn't matter, I think we can say it does. Younger women, those having an induction of labour, First Nations women, those in standard fragmented care or GP shared care, women with a previous mental health diagnosis, and migrant women coming to Australia. They're all out of all the stats we've looked at, and we've got quite a few other things that we haven't looked at that impacts it, but out of those, they're the top 8 things that increase birth trauma. Then let's have a look at the things that have the lowest amount of birth trauma, which we could say is the most protective against receiving or experiencing birth trauma. So at the very top is a privately practicing midwife. So in Australia, that is when a woman has a private agreement with a midwife, and a lot of the appointments will be done at home, and they may even plan and have a home birth as well. Then it's vaginal birth. Then it's midwifery group practice, having a spontaneous labour, and at the bottom is private obstetric care, but we need to remember they also had the lowest rates of vaginal birth. Sorry, some alarms going past me and the dog's barking about them. Okay, so what do you think? What do you think about what things increase birth trauma rates and what things decrease birth trauma rates? What are your thoughts about that? Does this similar to what you see in your own midwifery practice? Is there anything that surprises you or makes you think, hang on a minute, I'm not sure? Or do you agree that some of the things that you've seen also support that? Okay, I have about 15 minutes left. Is that right, Isa?
Yeah.
All right, well, I'll go through the next section, which is what is debriefing? And I think we have a very important role to play in debriefing. So what is debriefing? Now, we actually asked a question in our birth experience study, and it'll be in the Indonesian one, where we asked women, did you get an opportunity to speak with a healthcare provider after your birth? And we left it very loose like that, you know, just speaking to someone after their birth. But there are actually some, and then we use the term debriefing a lot, don't we? You know, we might use it if we've just gone and spoken to a woman, or a doctor has spoken to a woman about why she had a cesarean. We might use the term, oh, she's had a debriefing. But do we actually know what it is, and do we do it correctly? So there's a couple of types of debriefing. There's one that you do with women, which is a structured intervention with the intention to intention of mitigating acute stress reactions. There's also informal individual needs-based discussion. And then there's clinical debriefing, which is, you might have experienced as a nurse or a midwife in your clinical practice when something maybe untoward has happened, there's been a bad outcome, and then you've come together as a clinical team to debrief. And clinical debriefing is seen as an interprofessional meeting that occurs after a critical event and allows nurses and other members of the healthcare team the opportunity to review and process their experiences. In all of these definitions, there is a similarity. And that similarity is that it's a two-way discussion. Now, how often do we see a debriefing that is not a two-way discussion? If someone is going in and saying, well, I've looked at your notes and you had a cesarean because of X, Y, and Z, and you're lucky that we were there because we saved your baby's life, and that's it, thank you, goodbye. And the woman is just lying there going, what? And she doesn't have an opportunity to ask any questions or to get any clarification. That is not debriefing. That is not debriefing when we look at the scenarios, if we look at these definitions, sorry. So let's have a look at what women said about their debriefing experience. Oh, I've got another slide before then. So why would we debrief? So for clinicians, we might debrief because of a traumatic or challenging clinical incident, and for women, following their birth experience. And it doesn't need to be a traumatic birthing experience for debriefing. It's just an opportunity to talk through what happened. So we asked women about their debriefing experiences. 52%, more than half, stated that they did have an opportunity to talk to a healthcare professional about their birth, which does mean that almost half of them didn't as well. 47% of those women spoke to a midwife, and only 23% identified that as speaking with a doctor. Now, interestingly, there's probably a lot more that had a doctor go in and say, this is why we've done this, blah, blah, and then go back and say, I've debriefed her. But the women did not identify that as debriefing. Women are being very clear about this. They did not have the opportunity to ask questions, so therefore they did not see that as debriefing. But 47% did find that they could have that conversation with a midwife. But 37% of women who didn't have an opportunity to talk, so from that 48% that said they did not have an opportunity, 52% said they did. From that group, 37% of them would have liked to speak to somebody. So that's quite important as well, to understand that women are not always given this opportunity, but they wish they did. They wish they had spoken to someone. Now, one of the wonderful things about this study that we're looking at, or this part of the study on debriefing, is that women are very good at telling us what works and what doesn't work and what their thoughts are about it. Now, the person I've had doing this analysis is actually a medical student. So I've got a medical student who has to do a research project as part of her doctor degree, had to become a doctor. And she's been working with me for 2 years now. We nearly finished this project, and I hope that the paper will be written by the end of the year. We had 2,158 women leave comments about their debriefing experience, and then we analysed them. And what we found is that women could identify what was ineffective debriefing compared to effective debriefing. And I think that's really helpful for us as clinicians, because then we can look at that and go, well, we shouldn't do this, but we should do that. So some of the categories that came out of ineffective debriefing included things like the clinician using defensive language. So you can probably see this, people go in there and they say, well, we did this because of this, and, don't question us, and you'll just be grateful for what you got. Or if a woman does ask a question, they get very defensive back. Well, we had to, your baby was dying. We had to do something really quick, without really explaining what happened. Being rushed through. So something really quick, and not giving the time to explain and to allow time for you know, a two-way conversation. Women being told, you can have another birth. Like, how dismissive is that? The woman is trying to have a discussion about her traumatic birth experience, and she's told, oh, don't worry, you can have another birth. Get it right next time. That is so patronizing and so rude. Then there's the category of didn't help resolve feelings. So maybe they didn't ask her how she was feeling, or they didn't validate those feelings. She might be sitting there going, well, I felt really scared, and then they didn't go into that. Or that she felt very angry and upset, and they didn't look at it. They didn't help her look at her own emotions. They just kind of explained they justified what happened. They didn't help her process it. Alongside that terrible comment of you can have another birth is at least you have a healthy baby. Now, how many of you have heard that? It is like a continuous amount that comes out of people's voices all the time. Write in the comments if you've got an example where you've overheard that. At least you have a healthy baby. That again is dismissive to women's trauma. And even if she does have a healthy baby, but she's not healthy, she's experienced trauma, then how is she going to be able to care for that baby effectively? Do we want well babies but broken mothers to care for them? No. We want well babies, and we want well mothers to care for them too. And being in a traumatic environment and not having the opportunity to talk about the trauma means that they will be broken women going home. My dogs are deciding to join in. And the last one is they didn't listen to me. So again, going in, it could be rushed. There was defensive language. They were told, well, at least you had a healthy baby and you can have another. And then there was no opportunity. Okay, I've got to go now. Goodbye. No opportunity for the woman to actually talk. And remember those debriefing definitions? There was nothing about not listening to each other. Here's some quotes for you. A lot of counsellors are unprepared to deal with real birth trauma. Phrases like, but your baby is healthy, or let's just focus on the positives, are not conducive to healing. Or this one, a different OB came to see me 24 hours after the birth to discuss how my cesarean went. It was a very quick, brief chat, about 5 minutes at most. And I was so tired and drugged up on endone that I barely remember it. I would have liked a more in-depth discussion while my partner was present, and perhaps a couple of weeks later, so I could retain information a bit better. So women did also write in their comments about timing. So we've got quite a lot when we write the paper that will also come out about when women think this should be done. But what about effective, right? We want to know about the effective types of debriefing as well. And this is what women say works. This is the good stuff. This is what I want all of you to take home and start practicing. I got to ask questions and get clarity. I think sometimes as midwives, we're scared of women asking questions because what if I don't have the answer? I'm not a doctor. Well, actually, I am. I'm a doctor of midwifery, but still, you know, I'm not a medical doctor. I'm not an obstetric doctor. But you are a midwife. You know more than a woman who's not trained in midwifery. So of course you can answer those questions. And it's actually okay to say to a woman, I don't have the answer for that. Thank you for sharing that with me, but I will go and get the answer for you and I will come back. That is still being listened to. I was given time and listened to. So not rushing in for 5 minutes or while you're doing a breastfeeding check and you're checking that everything's, and you feel okay about your birth too, you'll understand why it happened, excellent, see you later. That is not debriefing. Sitting down, sit down, have a chat. Our First Nations women call that having a yarn. Sit down, have a chat, and actually allow the woman to have conversations with you. I had continuity. So women who had continuity of care with a midwife had a much better debriefing experience because the midwife knew them and knew their experiences and could have a chat. As a privately practicing midwife myself over many, many years, this was a big part of my job. It helped process my emotions. So remember, the previous one said I couldn't process my emotions. This one did. So the woman might be confused or scared or unsure or angry, and being able to have that opportunity to talk about what happened helped her process those emotions. And we know that if we don't process those emotions, they live within us. And therefore, if they're staying there, if that sadness or that guilt or whatever that negative feeling hasn't been processed, it will go on into her postnatal experience. Some women said they were able to go through their notes. So having a healthcare provider, midwife with them, and to go through what was written down actually was helpful. Because as you know, when you hit labor land, time, it's like a vortex of time, isn't it? And it's confusing. You don't know. You think something happened, but it happened 2 hours before or happened a minute ago and you thought it was ages ago. It's a bit of a time vortex. And the notes, the progress notes, can be quite useful for actually understanding what happened. But there's a caveat here. You must keep good notes for this to be useful. And finally, some women found that effective debriefing helped them plan for the future. They might, remember I said in my first week with you, the planting the positive feedback seed. If the woman's had a cesarean and you help her with effective debriefing, part of that could be planting a positive feedback seed. And it helps her plan for the future. So this is all one big quote. After all three of my births, my midwife sat with me and we discussed my birth. She explained different parts and I was able to ask questions. It was fantastic, as there were things I didn't realize, like when she asked me to change positions during pushing, that it was because she was worried about shoulders being stuck. I didn't know this, but because I knew and trusted her, I followed her lead and she looked after me. It was only after when she explained that it made sense. In that moment of my birth, she was worried, and yet I didn't know. I just followed her gentle lead. I love her for that and taking the time to explain that to me. I really love this quote. It gives me the warm and fuzzies. It really shows to me the power of midwifery, the power of continuity, the power of caring for women and being calm in the moment. And this ended up with the woman absolutely loving her midwife and trusting her even more because she knows that she would explain it afterwards. How does this quote make you feel? Let me know how this quote makes you feel. Has everyone had a chance to read it? Yeah. Okay. I'm going to quickly rush through this. This is about clinical debriefing, and I wrote about this when I was doing a clinical debriefing discussion. Now, there is this paper here, Towers et al., talked about the 5 E's, but this is for clinical debriefing. But potentially you could bring this into, so this is when you're coming together as professionals to discuss a scenario that happened. But I think some of these could be used in the debriefing that we do with women as well. You need to have someone who's experienced at doing it. You need to have a psychologically safe and supportive environment. You need to have the education and clinical knowledge and professional education. You need to be able to review the event for areas of improvement. And that's even important with women, to look at it and go, you know, there might be a time when you go, I think that wasn't best care. I think that wasn't a great thing that you experienced. We need to learn from that. And address the emotions of people involved in the event and follow up if needed. So if after the event, you know, or even when you've spoken to a woman, have the opportunity to come back to her and say, we had a chat recently about your birth experience, and you talked about a few things. I'm just wondering, have you got any follow-up questions for me, and have that opportunity to go back, because the woman may well have been processing things in her head after she's had the debrief. What if we don't do debriefing? Well, we know for staff and for midwives, we're going to have burnout or compassion fatigue. And for women, and midwives, this leads to more mental health issues. So what can we do to keep your positive mental health? Getting professional help if you need it. But that's also important for caring for women, that they have the opportunity to have debriefing. Staying positive, getting enough sleep, developing positive coping skills, and peer support. Peer support for you as midwives, but maybe even peer support for women. If you can see that this woman is really struggling, then put her in touch with maybe organisations that have peer support as part of their organisational support. So my final question for you is, how can you bring in effective debriefing into your own practice as a midwife? What are you going to do, and how are you going to bring it into your clinical practice? And that's me. I'm hoping this translated okay, that to remember that knowledge is power, and how powerful you all are. I probably shouldn't have done that through Google Translate. I should have checked it with someone like Isa first, but I did it this morning. You all are now, everyone that's listened to the 3 seminars, you have so much more knowledge now, and you have so much more power in your work as a midwife and in the care that you're going to be able to provide to women in the future. You really will be able to provide respectful maternity care. And remember that that knowledge is power for women that you're caring for as well. Encourage that they get further education around normal labour and birth and respectful maternity care. And thank you for having me for all these 3 weeks. I think that's me done.
Okay, thank you, Hazel. Maybe from the participant have a follow-up question, something like that. Yeah. But yeah, let me have a quick how to say, like, in my perspective, the sentence "at least you have a healthy baby" is really close with my environment, because yeah, and also what you say before is we need to focus in the positive, just in the positive way, without rethinking again about the birth trauma, how the mommy have the yeah, like a bad experiences about giving a birth, something like that. It's really make me have a goosebump, Hazel, because oh yeah, I forgot that, something like that.
But it can be damaging. That's the point, that when we say something like "at least you have a healthy baby," it's trauma, and that's important that we care for trauma.
Yeah. And also, yeah. And yeah, from Idelia said that she want to ask something. Yeah.
Okay. Hi, Hazel. Hello. Nice to meet you. Thank you so much for your presentation. I just want to share my experience as a midwife. As long as I observe our fellow midwives experience the birth trauma as well, not only the woman, but we are as a midwife, by exposed with, you know, negative experience of our patients, of other mothers, and we see it by ourselves. And many of my friends, midwife friends, end up having cesareans during their labor, and yeah, and they share how hard their experience, and etc. And do you have any advice for us how to deal with the birth trauma of our patients, and how we do that? Thank you.
It's very challenging, because, you know, the experiences that we have obviously impact then potentially impact the care that we give. I know when I had my cesarean, I hadn't realized how painful it was the next day trying to get up. And then when I cared for women, when I went back, I was really careful during that time. But then also having a VBAC obviously sent me on this journey of healing and redemption and changing it for more women. But I think a detrimental impact is that we are concerned that women are going to experience something similar, so we might not really understand the positive impact of vaginal birth if we haven't experienced it ourselves. And as people who are seeing birth trauma, not only have you experienced it, but then you're witnessing it, you're taking on that heavy load, and you've got more chance of getting burnout and that vicarious trauma yourself through watching it. And I think it's a conversation that you need to have along midwives to go, how can we support each other? This kind of group is fantastic because you can come along and you can learn about the research and get support from each other and realize that on the big scale of things, we've got to keep the big scale of things, that normal labor and birth is important. But it's not easy at all, Aldila, and I understand that would be really challenging to do. But keep being informed about normal labor and birth. And if you're never seeing it, then reach out to the midwives in the community that are doing it and to see how birth is. And keep listening to those positive birth stories as well, so that you can also see the benefits of it. But it is very difficult when we hold our own trauma. And also having the opportunity to talk with others and even professionals about the trauma that is being held. Because as they say, if your cup is empty, oh, you can't see my cup. If your cup is empty, you can't care for others. And so what is it that fills your cup up? And being with other midwives and going to midwife organization meetings, going to the ICM, like those kind of things, they fill your cup up. And then you come back and you get excited to work in midwifery again. Thank you.
Thank you so much.
You're welcome.
Okay, thank you, Aldilia. We have Ernie Rosita David. Yeah, raise hand, please.
Hello, good morning, everyone. Good morning, Hazel.
Hi, Annie.
Yeah. Hey, thank you so much for your presentation. I really enjoy it. Actually, I have several questions related with your presentation. The first one is about oxytocin administration. It's not really surprised about the result of your research because I believe that more intervention means more worse event for mother and the baby. But I'm just wondering about oxytocin administration specifically in the third stage of labor, because in Indonesia we have no psychological placenta. All women must get like active management. So do you think that it is like a specific correlation in this standard? And then
I mean, the use of oxytocin was during labor, about, getting the induction of labor going. We don't have any data that we've done or that I'm aware of that looks at active management and the impact on trauma. I think where it can come out is if a woman didn't want that and then she felt that she was forced to. So if she made a choice to not have syntocin on or oxytocin during active, if she wanted a physiological third stage and then maybe that was taken off her and she wasn't given the option, that could be traumatic because she had that loss of control. But otherwise, there's a variety of different evidence out there on the comparisons between active management and physiological third stage, and I think that's got to come down to best practice in the context that you're working. Certainly in a home birth environment, when I had good access to hospitals, many women wanted a physiological third stage and they would have it, but I would always have syntocin on there as a treatment if she started to have uncontrolled bleeding. So I think it does depend on the context and what's available. And I could understand that in some of your situations that are very remote, you know, the practice of using oxytocin is probably safer than waiting for a bleed and then traveling, you know, having a long travel to go to somewhere with the capabilities of being able to treat that. So, you know, I think that's, but I think where we can relate it to trauma is if the woman didn't want to have that, and then having it against her choices.
Okay. Yeah, thank you so much, Hazel. I have another question. Is that okay?
Absolutely.
Yeah. About your last topic about debriefing, I'm just wondering, is the term debriefing the same as reflective birth? Because I'm aware in some countries have a specific service about it. For example, the UK. The UK have like birth reflection unit that provided by the midwife. So is it like same with the briefing or not? Because in Indonesia, we have no specific follow-up service after the women giving birth, and then we ask their experience or something like that. Yeah, just want to clarify about it.
I think it is the same. And I think there's a lots of different language around that. There could be reflective birth services, debriefing, postnatal counseling. There's not one recognized term for it. I think sometimes the midwife services don't want to use the term debriefing because it sounds more formal, or it sounds, you know, like they should be done by a psychologist, not by a midwife. So maybe reflective birth is a bit less formal. But I think, you know, when we look at what women say is effective versus ineffective, these are certainly skills that we can do as midwives. We have the skills to be able to sit and to listen and to clarify and to identify emotions. And I think midwives are very good to know if it goes beyond our scope, because we're not psychologists, we're not psychiatrists. We know to refer on if we need. But it looks like most women just want to have a chat with a midwife and have that opportunity to debrief or to have a conversation. I think the complication in language can be, it's got to be language that is recognized for its service. So maybe if the language in the country is debriefing is a recognized term, and then you bring in something else, women might not know to go to that service because they don't understand the terminology. So it's, you know, we've got to have that kind of, I know that in Australia they might want us to use a different term for lots of things, especially obstetric violence, but we've got to keep the recognition. Otherwise, if we just come up with new terms, then it might be a disservice to women because they don't know what it is that they're going in for.
Okay, thank you so much, Hazel. Maybe the last question from me. So I'm just thinking about how we can identify earlier about the birth trauma in antenatal visit, because sometimes in my observation, most of midwife or like medical profession as well, we just point out in the history of the previous birth, just how about your mode of birth and something like that, how we can get more voice from the women about their birth experience. Yeah, that's it.
Well, I think that can be done relatively easy by saying to the woman, tell me about your birth experience. Just make it very open, not the closed questions of the type of birth or were you induced, blah, blah. Actually just having an open question with an open stance, so not crossed arms, but open stance, and saying, tell me about your birth. And then if that doesn't work, you could say, tell me how you feel about your last birth. Like, just ask the questions in an open and in a caring way where you've got time to ask that question. Then I think you will get the information. In my many, many years of doing research on women, I know that they will tell you. If you ask the right question, in my surveys, if I ask the right question, I get pages and pages and pages and pages of comments. If you ask it in the right way, women will tell you. We like to talk, especially like to talk. So if you put it in a way is about your life, how it made you feel, then you can get that out. Or if they don't want to go there, you might say something like, tell me how you feel, tell me what you're thinking about your next birth. Do you have any fears for your next birth? And then it might come up about their previous birth without them even realizing that's what they're going to talk about. But also, let's remember, on the first week, do you remember I talked about those 3 ways of doing the birth plan? The drawing of the birth plan, the ideal birth, the worst case birth, and the worst case made better, in the control chapter of your book, if you've got my book. If a woman doesn't feel like she can verbalize it, she might be able to draw it. And so that can also be a conversation to have. Does that answer your question, Annie?
Yeah, thank you so much, Hazel. I think that midwives are very busy to listen the women experience. We have like restriction of time in antenatal visit as well. Yeah. Thank you.
I know it's tricky. But it's worth it. I know when I was doing my workshop once in somewhere in Australia, I was doing my workshop, and a midwife was saying that she works in an antenatal clinic, and she's just very, very busy. She doesn't work in continuity of care at all, and she felt like it was wasted time if she was asking people about their previous birth. And then a student midwife who was also a doula, she spoke up in the workshop and she said, it is not wasted time. She said that she often hears from women that the woman will say, there was this one midwife during my whole pregnancy that cared enough about me that she asked how I felt, and that she went away feeling so positive and so listened to. So even if you don't get everything else ticked off in your checklist for that appointment, you could be remembered as that one midwife that cared about how she felt. And I know that I would want to be that person.
Yeah, thank you, Hazel. It's really interesting. Maybe other participants have the question. Please raise your hand, turn on your camera or your microphone, and you can directly ask to Hazel, or maybe.
Can I ask, Isa, if anybody has their books with them, if they've arrived at home, if we do the screenshot at the end, if they can hold their book up, if they have their book with them.
Oh, okay. Yes. Mungkin untuk teman-teman yang sudah order bukunya, nanti di sesi terakhir kita bisa take a foto bersama dengan buku yang teman-teman sudah order gitu.
I'm not sure if they've arrived at your homes yet.
Okay. Maybe another participant have the question. You can also, type on the chat box. Okay. If don't have another participant have a question, maybe I want to ask as a last question, Hazel, because we have a limited time. This is from Google Form, and someone asks about how to create a great opportunities for a mother to grow and move on from birth trauma. It is related with the Aldelia question, but she adding, whereas she had a bad environment such as unhealthy lifestyle, unsupported family, and minimum self-awareness. Yeah, maybe you have.
It can be very challenging moving on from that, and knowing as well that this can lead to more mental health issues in the perinatal period. I think it's I guess that birth debriefing or reflection has a big impact on it. Having the opportunity to talk about what happened is often, women might need a few sessions like that, but that might be what they need. Also getting some pastoral care or some supportive care from counsellors and psychological support that can happen in the community. Peer support can be very helpful as well if there have been women that have had traumatic births and moved forward from that. And yeah, anything else that you really would expect for women who've got mental health issues? It's really looking at that ongoing support and opportunity to get treatment. Sometimes this can lead to something like PTSD or to postnatal depression and anxiety. And if it has led to that point, or you're worried that this is leading to that point with a woman, you can do the screening for EDS, the Edinburgh Postnatal Depression Score. And if she is scoring high on that, then it is your responsibility to refer her on to her community doctor, to her psychological support, because it might be, if it has led all the way through to depression, she might need more support, such as talking therapies, counseling, and maybe even medication. You always need to be aware of the severe mental health issues that can happen with women, such as postnatal psychosis, and trying to identify the differences between being a new mum and not being able to sleep because your baby is awake, and being a new mum and not being able to sleep because even though your baby is asleep, you are getting flashbacks and thinking about the birth all the time. So those are questions that, as a midwife in the postnatal period, you need to dig a bit deeper and see, is this actually some mental health issues that she's having, and therefore referring on to whatever you have in your communities with support for women with mental health issues in the perinatal period.
Okay, thank you so much, Hazel. Yeah, for the enlightening presentation, and we can learn from Dr. Hazel, guys, that even the birth trauma also can be the woman can move on from that with our helping as a midwife. And please believe that our group is being the strengthening each other, and we hope midwifery practices and others will be better than now. And I want to again thank you to Dr. Hazel for sharing her expertise and experiences, and also want to thank you all to the participant for their active involvement during the webinar. Thank you all for being part of today's webinar, which is a last session of Midwifery Forum, Respectfull for maternity care. And we hope you leave here today with a deeper understanding and appreciation for the vital role midwifery plays in healthcare. Thank you for all participants, and I will return it again to midwife Geza. And please note we need to take a photo with the Hazel book. Thank you. Back to midwife Geza.
Okay, great. Thank you, Midwife Iza, and also Dr. Hazel Gideles, our amazing speaker today. So before we close this webinar, we have to take some photos together. And maybe for the participants who has already bought the book from Hazel Kidel, you can also prepare and show the book like in front of the camera. So I will give you a second to prepare and turn on your camera. Let's wait for some minutes to give another participant to turn on the camera. All right, I think it's enough for the preparation. For the operator, please take the capture of our photos. I will count from 3. 3, 2, 1, Smile. Okay, once more, I think. I will count again from 3. 3, 2, 1, smile. All right. Well done to everyone. We truly appreciate your attendance and cannot wait to see you again in the next event of Ruang Bidan Indonesia. We apologize if during these webinar sessions there are still shortcomings from us. So thank you for coming. Have a great day, everyone. Good afternoon. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
See you next
Thank you.
time.
Thank
Thank
you.
you so much, everyone.
Thank
Thank
you,
you, Hazel.
Hazel. Thank you, RBI.